So it's time. We can start. Welcome everybody to this co-sponsored symposium for EuroPCR. The topic is Paclitaxel DCB, and I'm so happy to see a lot of people here. We have a great group of experts, interventionalists on DCB technology. And finally, we are here after 2 years because we started working on this project more than 2 years ago. It was December 19, and then we know what happened, and then the following year, and so on. And now we are here. I'm really, really proud to be the anchorman of this group of experts on DCB. Which are the goals of this session? First of all, to understand the role of Paclitaxel DCB in modern era interventional cardiology. Then to learn how to correctly prepare the lesion and obtain the best from this technology on the long term. This is what we want to achieve. We don't want to achieve an immediate result like with stents, but we want to keep the patients away from our cath lab. Okay? This is the goal. To understand the differences and advantages of Paclitaxel drug-coated balloon versus drug-eluting stent, current era drug-eluting stent, and to understand the role of blended therapies in a complex lesion setting. I took these blended therapies from Patrick Serrayus yesterday. I love it. I don't use any more hybrid therapy, but blended therapy. I like this. So, for the future. Fondazione Ricerca e Innovazione Cardiovascolare has gathered this symposium, which is here thanks to an unrestricted grant by B. Braun, Medtronic, and Biotronic. So thank you for letting this all of these people be here. And this is the group. I tried to find the most weird picture of each of us. Probably only Fernando has a normal one. But this is the group of people that are leading this project. And so please ask. We have 2 long discussion sessions and try to let this session to be the more interactive possible. Okay? Thank you. Robert.
Bernardo, thanks very much for organizing the session, and thanks for finding a photograph of me in an Italian cycling jersey. But pleasure to be involved and to see everyone again in person and to see so many people here turned out. I'd like to take one moment just to introduce the discussants, Fernando Alfonso, who you know well from Madrid in Spain, Waksman from Washington, D.C., and Tuomas Rissanen from Finland. And without further ado, then it's my great pleasure to call on the first speaker, who's Antonio Micari, and he's going to present to us on paclitaxel and supposed increased risk of mortality 2 years later. While he's getting set up, I'll remind you, please, to interact via the app. We're very pleased to have Tom Adriaenssens sitting in the audience, who's the chat master for this session, and he'll direct any questions that you have this way via the chat. Thank you.
Thank you, dear anchor person, moderator, discussant, and dear colleagues. It's a pleasure for me to be here. I ask you to have I will do myself, my slide. We start with a problem, with a question that occurred 2 years more or less ago, about a concern about mortality, about safety of paclitaxel. These are my conflict of interest. And of course, we know, at least in peripheral, that paclitaxel is effective in terms of reduction of restenosis. But in December 2018 appeared a meta-analysis that we were talking just after about Katsanos with some concern about mortality. After this occurred a lot of different action by FDA that issued 3 letters, by society, by practitioners that changed their mind or they a bit the way they used the drug-eluting device in patients. So this was the meta-analysis showing that at 2 years and 5 years there was an increased risk of mortality after using paclitaxel device. Of course, there are some criticism about this. First of all, it was a meta-analysis of trial that were not designed to examine mortality. There were a lot of missing data. And of course, what is, I think, very important, is the most important point, there was no patient-level data, but just summary-level data. The examined data were very heterogeneous, stent and balloon together, patient with wide range of comorbidity, different clinical presentation, critical limb ischemia, and claudication, device with different platform, carrier, and dose. Why should we take care? Because we are talking about mortality, endpoint. And of course, the population was claudicant. Claudication doesn't kill. Mortality, of course, is an endpoint. But if we look at mortality, was much lower than it was, for example, for simple PTA or for sirolimus stent. After that, we started with the meta-analysis. We started with meta-analysis. We had 3 letters from the FDA. First, in January 2019, just after. Then the third and the last was August 7. I said that for individual patients at very high level of risk of restenosis, there should be a benefit, but you should discuss with the patient the effect, the risk-beneficial effect. But after that, there was an incredible answer from reaction from the practitioners, from the scientists. We have a lot of studies, starting from the sweet part that was published in 2020, in December 2020. It was a randomized trial. At the time of the meta-analysis was post the enrollment. They did an interim analysis. After this, it showed in 2,289 subjects with a mean follow-up of more than 2.4 years. There was no difference in mortality between drug device and not Paclitaxel device, either in claudication or in claudication. After that, there were a lot, many studies, population study, retrospective, prospective, randomized trial that I show just in a quick way, just not to be boring. This is a veterans administration analysis, 10,000 patients or more with a mean follow-up of 20 months. Again, you would appreciate the Kaplan-Meier with no difference between the Paclitaxel and not Paclitaxel. The safe path, this study that was published in August 1, 2021, is 168,000 of patients, so many patients. With a long follow-up, you would appreciate in days more than 1,700. Again, there is no difference. And the Optum, that is an analysis of Medicare Advantage patient, 16,000, more than 99% completeness of Medicare. And still, same answer. There is no difference, Paclitaxel, not Paclitaxel. And this is just because it's a randomized trial that was about rivaroxaban versus placebo, but it's a subpopulation of just 4,300 patients that were treated with or without drug device. And again, there is no difference in terms of mortality, but there is a huge difference, or at least it's not huge or not huge. It is significant. It is enough difference in terms of effectiveness. So it's effective, but this we knew already, and looking this study is also safe. And when another meta-analysis that is similar in terms of robustness is not that robust because it's a summary level data, but included more study with the longer follow-up, showed that the relative risk is 1.19 versus 1.93, the consensus meta-analysis. So that means that we started in this way. We started with a difference in mortality of this that I would apologize for this. I would call rude meta-analysis at that point. That it was important for us. We thanks Katsanos to give the chance to study better and more what happened. And in different setting, with different physicians, with different science, in different setting, we had a result that is showing that there is no risk for mortality for Paclitaxel. Then there was another call for amputation with a similar meta-analysis by the same author, with the same criticism of the first meta-analysis, and the result was exactly the same. Different study and more accurate study showed that there is not true. So this is my last study, just to conclude that all independent analysis to date of provided evidence of no mortality difference between patient treated with Paclitaxel device compared to conventional device, at the same, exactly the same result, the same conclusion can be drawn for amputation and Paclitaxel. There is no dose effect and no risk of increased mortality. And I thank you for the attention.
Okay, I remind you that we have 2 discussion sections with 2 polls in the beginning of each, so we go on with the lectures. The next speaker is Raban Jeger, which will update us on Paclitaxel DCB in de novo and ACS indication. Raban.
Okay, thank you very much. First of all, I want to welcome you from my side. It's really great to see all of you personally and not via Zoom or any other spooky software which never works as I wanted to. So it's really nice to be here. My name is Raban Jeger. I work at the Triemli Hospital in Zurich, and my task today is to speak about the indications of Paclitaxel DCB in de novo lesions and ACS. And why is that? Paclitaxel, because for sirolimus there is almost no data. These are my conflicts of interest. I have been supported by B. Brown for the Basket Small 2 trial, research support. And I want to start with this slide here. As you know, pathophysiology of ACS is based on endothelial function, plaque rupture, there are dissections, there are endovascular thrombus formation, vessel occlusions, and normally all these problems are treated with drug-eluting stents. However, the drug-coated balloons, they have the advantage that there's no implant, no metallic implant, and you avoid late problems of this metallic implant. However, the efficacy and safety in this context of acute coronary syndrome is not really known. DCBs might have the problem there that there is not a good drug delivery to the vessel wall, and normally or eventually there needs to be a strategy of deferred PCI. However, with DS we have other problems. Stent apposition can be a problem in acute coronary syndrome and in thrombus, and with that the risk of stent thrombosis. For ACS, there is a lot of data in this field, and I want to start with this here. Bernardo has published a Piccoletto trial. It was not a trial of ACS patients, but there have been lots of ACS patients in this trial, as much as 44%. And you see here they compared Elutax against science, and with a really good angiographic result and a good clinical result. Another large trial is the Basket Small trial in smaller vessels. As you see here, there was a large subset of ACS patients, 28%, and there was a subgroup analysis for this trial just published recently, and as you see here, that the DCBs performed really well with lower event rates for MACE. However, the interaction was not significant, and this lower event rate was driven by low rates of cardiac death and non-fatal MIs. After 1 year, the interaction was significant for both of these endpoints. However, after 3 years, this was not the case anymore. A dedicated non-STEMI trial was PEPCAT from Bruno Scheller, and you see here that both strategies were non-inferior. However, there was a 15% stent bailout rate in the DCB group, and in the stent comparator group there were only 44% of DES, and so this is a little bit a mixed bag here. When you look at MACE, there was not a difference between the two groups, and when you only look at the DCB only, the BMS only, and the DS only group on the right side of this slide here, you see here that the DCB only group performed the best, however, without the statistical significance. Trials in STEMI exist as well. This is data from the Amsterdam group. On the left side, you see the PAPA trial. PAPA trial looked at Panthera lux in the setting of STEMIs with a quite good result. It was just a trial with one arm. However, there was a bailout stent rate of more than 40% here. And they tested this strategy in a larger trial, the Revelation trial, where they had an endpoint of FFR after 9 months. And you see here that both strategies regarding FFR were similar. And this is a large meta-analysis of smaller trials in STEMI. You see here that the clinical endpoint of MACE was similar in both groups, DCB and DS. You see here as well that angiographic follow-up was slightly better for the DCB group. It is important here to mention that the bailout stent rate here was between 6 and 18% for DCB. So I already come to the conclusion. I've shown to you that there are and were several randomized trials comparing a strategy of Paclitaxel coated balloons versus DS in ACS patients, in non-STEMI and STEMI patients. In all these trials, there was a good efficacy and safety profile of Paclitaxel coated balloons with at least similar results as in the comparator group. And it is important to note that in the DCB treatment of ACS, there is a certain stent bailout rate, in some trials up to 41%, depending on the indication. And to make the take-home messages, in ACS, a primary strategy of DCB, PCI, is safe, and the intervention eventually needs to be complemented by bailout stenting or a deferred PCI after establishing a TIMI-3 flow. Thank you very much.
So thanks very much, Raban, for a succinct overview, and thanks for staying on time. One more presentation then before the discussion, and that's John Graham, who's going to present to us a case with angiographic follow-up and lumen gain. So, John.
So just going to present a quick case following conflicts. So this is a 68-year-old gentleman with multiple cardiac risk factors, and this will become more relevant later, previous left nephrectomy for renal cell cancer. He actually first presented 10 years ago as a false positive STEMI. He had chest pain with what was felt to be ST elevation, but he had minor non-obstructive plaque and he was managed with primary prevention. Just over a year ago, at routine follow-up, he was found to have enlarging lung nodules that was felt to be related to his previous renal cell cancer. And he was being planned for a wedge resection, both diagnostic and curative. But coincident with this, he began to develop exertional chest pain. He uses an exercise bicycle every day, and he was getting more and more progressive chest pain. He could only manage 4 minutes on his bicycle. And on a stress echo, it was very strongly positive at a low time, but rate pressure product was pretty high. And the echo showed his inferior wall became akinetic at peak stress, which coincided with his chest pain. And he was referred for an angiogram. And the angiogram has shown that he's got a chronic occlusion of his distal right coronary artery that was backfilling from the left system. And he was actually taken off the table. He was commenced on a beta blocker. His symptoms improved a little bit, but because they were going to be intubating both bronchi and with selective ventilation, there was a feeling that the hemodynamic upset may be pretty extensive, and there was reluctance to operate with this. And he was referred back for a consideration of angioplasty. Initially, the angioplasty itself was fairly straightforward. We got through with a polymer jacketed wire, switched out to a regular wire, and we ballooned with a 2O20 balloon and got resumption of distal flow. And the feeling was that to stent this, we were probably going to have to go from here, and he has plaque. And although there's been a lot of work with high bleeding risk patients, and they may say that you can, but this is almost 10 centimeters of stent, and I would be reluctant with abbreviated dual antiplatelet therapy. So it was further pre-dilated with a 3O balloon And then a 3.0 millimeter Pantera Lux was inflated at 7 atmospheres for 2 minutes. The beauty is this was occluded, so we left the balloon up for a couple of minutes with no symptoms. And the final angiographic result, and you can see there is a small, fairly localized type B dissection, and that persisted despite re-inflating the Pantera balloon for a couple of minutes further. But we accepted that, and he was discharged home. He was given 2 weeks of dual antiplatelet therapy duration purely because we decided that. His surgery was then delayed by another week because of COVID. Not him, the surgeon had COVID. And then he underwent uncomplicated wedge resection. And the pathology showed that this was indeed related to his renal cell cancer. And he commenced immunotherapy with a good response. And then 6 months later, he called my office saying that he'd had his chest pain back. And he actually said, I think I need a stent now. He was slightly nonplussed, bemused after the procedure when we said we had just ballooned it and didn't put a stent in. And the reason for that, but he thought the stent was going to be the better option. We didn't do a stress test. We went straight to an angiogram. This is the angiogram that was taken at that time. And in the interest of time, I actually went back and looked at his angiogram from 10 years ago, and the distal right coronary is very similar to what it looked like 10 years ago. So we reassured him, and he is now back on his bicycle, and his chest pain has gone away, and he is doing very well. Places where I increasingly use my drug-coated balloon in practice, obviously restenosis, but we're using it more and more with diffuse disease and trying to avoid DAPT. And I think Dr. Ferenc is going to talk about the use of it with investment procedures. Thank you.
Thank you, John. Very nice didactical case with the lumen gain, which is one of the most fascinating topics in the DCB for Paclitaxel. Now we have the discussion time, but first I would like to launch the poll. So I invite you to vote. I'm going to read the question: which is the main advantage of Paclitaxel versus sirolimus in a DCB platform, in your opinion? Its lipophilia allows it to enter the vessel wall faster. Its pharmacokinetic properties allow it to reach the adventitia and exerted lumen dimensions increase, or it has more solid data in terms of angiographic performance?
So we'll allow a couple of moments for you to answer that via the app. Maybe while we're waiting on the result, we'll start with some of the questions that are coming in online. Fernando, balloon inflation duration in de novo disease, maybe in restenosis. What's the optimal duration of balloon dilatation?
I mean, with most stents, we got data that 30 seconds is good enough, but we try, all of us, trying to keep it a little bit longer, up to 1 minute if there is no ischemia, and I think there is some data with different balloons.
And John showed a nice case. If you've got CTO, then you can go longer. Of course, if it's left main, then you're limited, but most of the time 30 seconds, I think, is well tolerated, and then you can give a second inflation.
Yeah, minimum of 30 seconds, yeah. In the left main, it's difficult more, but many patients may also tolerate up to 60 or even more. So I agree with you. Robert, do you want to... Oh, they are still voting, so we can wait a little bit.
Okay, well, there's one other technical question then. I don't know if Tuomas wants to take this one then. So discussed balloon inflation, but one of the other problems with drug-coated balloon is before you get to the lesion, you lose medication wash off. So what we do when we open the Y connector to bring in the balloon, we start the clock and we measure dwell time. And until we get to deliver to the lesion, and then we start inflating, and then we stop the clock and measure the inflation time instead. So what do you think? Is that overdoing it, measuring things like dwell time or the time taken to get to the lesion? Do you think, is there a time point where you say, listen, it's taken too long for the balloon to get to the lesion, I'm just going to have to take it out and take a new balloon?
Yeah, it's a good question. We don't measure any specific time, but if it takes 4 minutes or so, we take a fresh balloon. And I think there are also differences between balloons. Some balloons tend to, scatter their medication from the surface. So, and it's very important that you have equipment, guideliners, 2 wires to make it quick to the lesion and spend some time.
Yeah, I mean, I think the guideliner point is a good point. If there's any tortuosity, it should be resolved beforehand. Sometimes the guideliner can assist, and there is some non-randomized data showing better results with systematic use of guideliner when you're delivering DCB. Bernardo, do you want to have a look at the results here, or should we discuss them?
So I think this is the final result. So the majority of the people here thinks that the lipophilia of Paclitaxel think that it is the major advantage, because it will allow it to enter the vessel wall faster with 57%, and we have a 28% pharmacokinetic properties allow it to reach the adventitia, which is something which is hypothesis generating, but we have some good data also from the very beginning with the first studies done by the group of Bruno Scheller and others, and there was a paper, I think it's Circulation 97 from Axel. I don't know if you know this physician, and they showed that Paclitaxel was directly going to adventitia exerting its effects, but it was just in the pre-DCB period, and only 50% think that it has more solid data in terms of angiographic performance, and this is agreeable by my side. What do you think, Ron, about this poll? What have you voted?
So I think that this is a wise crowd, and they know the answer. I would tell you from the study that we did with Raban, and we saw evidence that the drug stays for a long period of time, and it's sticky, and we know this was how all the drug-eluting stents started with Paclitaxel for the lipophilic effect. So I don't think we should debate it too much. I appreciate the other answers, but I'll go with the majority.
I mean, I think you could make a case for each of them to one extent or another, and I mean the distribution story throughout the vessel wall. I think, like you allude to, there is data behind that, and whether or not that's behind the positive remodeling, possibly it is. And in terms of the data that's available, I would say it probably is stronger at the moment with Paclitaxel.
I would maybe say one thing, that we cannot look at this. This is such a simplicity question because it's not about just the drug. And as we know, you cannot just dip the balloon in a Paclitaxel solution and say, I have a drug-coated balloon. So there's a lot of other components that has to take into consideration. But the lipophilic aspect over sirolimus is known, and I think it's probably the majority of the part for the answer of this question.
Yeah, I have a question for Antonio. Antonio, you are one of the most experts peripheral guys on DCBs. And you have probably performed hundreds of PTAs, just leaving the vessel highly dissected with Paclitaxel. Among the experts, we think that a good dissection also for the coronary tree is a good way of entry of the drug into the vessel wall. So can you comment on this, given your expertise in the periphery?
Well, I think thank you for the question first, Bernardo. While I'm thinking the answer, I think that there are two perspectives. There's the patient perspective and the physician perspective. When we have a dissection, the physician perspective is to stent and go safe at home. But not always I think that put a stent, a prosthesis in a coronary or in a peripheral vessel is the best for the patient. I think all the data that we have seen just now show that it's probably safe and effective to leave as it is, not to put a stent, not to put the prosthesis. There is a big concern, I think, in terms of elution. This is the real difference, because this, of course, is not just the mechanical effect, not at all, it's a biological effect. So we should elute enough Paclitaxel for enough time in the vessel media or even close to adventitia. And I think that another big discussion point will be the vessel preparation. Vessel preparation is crucial to allow the DCB to have the real effect, so to transfer the drug in the vessel wall. I think this will make the real difference in terms of efficacy and safety, more efficacy than safety, of course, of the drug-eluting balloon.
So Ron, maybe a question here for you that's coming through on the chat. And it's saying, I suppose what they're asking for here is a bit of a historical perspective. I'm not saying that's why I'm going to you on it, but the mechanism of DEB is similar to balloon angioplasty with drug this time. And we know that balloon angioplasty is inferior to stent. How do we marry this with the data that when we moved to systematic stenting more than 25 years ago? Is there a knowledge gap? Was systematic versus selective stenting properly investigated? And why is the uptake of a DCB-only approach relatively low in this day and age?
Yeah, so on the longitudinal phase, you have to recognize that there is all the time improvement in technology and innovation. So the stents that we're using today are not the stents that we used 25 years ago. And many of the technologies that came into the market, including DCB, were about to overcome issues that we had with drug-eluting stents, like stent thrombosis, like things that has been associated with a lot of MIs, etc., etc. So I think what happens after that is that stents tackled the dissections well and prevented the abrupt closure. And that part actually brought to some very famous individuals that say, we'll never go back to the balloon because the stents give you a predictable result. Although they had to confront the issue of stent thrombosis and other complications of stents, which is restenosis, which is still a serious event. So the drug-coated balloon is, to my view, playing a race all the time with another technology. And and recently, if you look one-on-one, there are a lot of studies that shows non-inferiority. So it comes basically to the simplicity of the procedure from the operator. The profile is the same? How many crossover of balloon you have to go to dissect it, and you need to go to the stents. I think, in my perspective, you should tailor individually the technology to the patient and to the lesion. And that's where we should look. So the history is nice, but we live in the present and we're looking into the future. And in that case, if we have a very distal vessel with a small diameter, you don't want to put the stents if you can get a good result with a coated balloon. If you have a bifurcation and you can do the sidearm just with the balloon, you'd like to do that. Acute MI, sometimes we see a lot of malapposition with stents. So it's really individually, case by case. We cannot make any more general statements.
Tuomas?
Yeah, and a very important point is that if you look at the randomized trials, the recent ones, basket too small, and then our debut trial, there were no single acute vessel closure. If you follow the international guidelines, no recoil over 30% and no flow-limiting dissections. And also in the registered trials, the acute closure rate is about 0.2, which is seems to be lower than the DES thrombosis rate.
Okay, thanks for that. Fernando, please.
Yeah, very quickly. Regarding the mortality issue, we are all here mainly cardiologists, I guess, and a part of the data coming from the peripheral, which is quite reassuring, as you discussed, there is a beautiful meta-analysis by Bruno Scheller only concentrated in the coronary space, right? Mm-hmm. And then there is also meta-analysis focusing in de novo lesions and also in stent restenosis, and there is no signal whatsoever regarding any safety issue, and in fact the trend is in the opposite way. And just quickly going to the pool there, well, there are many reasons to choose one drug over the other. Paclitaxel is very appealing from the drug-coating balloon area, but we got plenty of data, and we need this kind of data also from the Limus kind of drug-coating balloons. So to me, getting this data is paramount.
But I'd like to comment just on the US approach with FDA, because Fernando asked me before, what's happening with the FDA? Why don't they change the recommendation? They're not aware to the data. So I live in Washington. I'm very close to the FDA regulators. I asked them the same question. My understanding, they're waiting for 5 years data for the randomized studies in the US. Once that data will be available, they would change the recommendation. They didn't say you cannot use it. They just said we want you to be aware that there was that kind of data that was available. But I don't think that they want to play ping pong here. So they're going to wait for 5 years from randomized clinical trials. They're not going to take one meta-analysis versus another meta-analysis. I trust that that data will show that there is no mortality signal, there was no smoking gun, and only then the FDA probably will change their recommendation.
Okay, well, thanks for that interesting insight, Ron. I think there's a lot more questions here. Maybe we'll have time in the second discussion session to deal with some more of those. But in the interest of time, let's move on. And the next speaker is Bernardo Cortese, and he's going to talk to us on DCP application in the complex lesion setting.
Yes, thank you, Robert. The question is now if we are ready to use the DCBs, Paclitaxel DCBs for a complex lesion setting. There is, I have to admit, a paucity of data about this, but there is a growing experience in a setting where a drug-eluting stent is not facing very, very well. First of all, this is one of my mantra. When we implant a stent, when we implant a drug-eluting stent, we implant metal, which is forever. Okay, everybody of us know this topic, but after 1 year, metal is metal. Okay, remind this. After 1 year, the metal that you have implanted is metal. In fact, this study, but many others are showing that the event in that vessel, in that lesion, are the same as it is in the case of bare metal stent. First point. Second point is that with any drug-eluting stent that you are implanting in the patient, you are not flattening of the curve of the events. Okay, you have a 2%, 3%, depending on the complexity of the lesion that you have treated, but the events go on in that lesion, and I'm talking about DOCI, so hard events, not angiographic restenosis. So this is not a complex setting, okay? I was talking about normal lesions. Real-life patients often experience a complex clinical setting with many features like history of MI, previous PCI, malignancies, history of bleeding. Bleeding is one of the most interesting topics in interventional cardiology in the last 7 or 8 years. Then there are procedural characteristics. Now we are treating patients that 10 years ago, 15 years ago, we didn't treat. Okay, CTOs is one of these, but another topic is calcification. Now we have tools, very effective tools to treat calcifications. And then what is happening? It happens that we treat more patients and more complex patients. Do we have data with drug-eluting stent for these patients? No, we don't have data. Okay, this is the point. And real-life patients are like these ones. Okay, we want to treat this type of patients, and then we pave these patients with highways of metal and drug-eluting stents. With paclitaxel-coated balloons, we have some potential advantages. We have already discussed about this ability of a good paclitaxel DCB, which means the ability of creating a lumen enlargement after 3 to 4 months after the PCI. And this has been shown at least in these 2 studies. And interesting, again, I come back to the dissection, this quite complex to read, but very interesting and very well designed study by this Japanese group is showing how there is a direct correlation between the dissection index, so how much you dissect the lesion, okay, unless you have a flow-limiting dissection, where then in this case you have to place a stent, obviously. But the more you dissect the lesion without creating an impairment in the flow, the more you will get in terms of healing and lumen enlargement by means of DCB with eluting paclitaxel. And at the multivariate regression analysis, the strongest predictor of lumen gain was the dissection index. Okay? This is an important message if we want to treat this type of patients. We have already seen the results of Piccoletto 2, but I want to underline the fact that with paclitaxel, 2/3 of the patients may incur into lumen enlargement. 2/3 is a very big number, which is not comparable to POBA, okay, and not comparable to the data that we have now with sirolimus. And then there is a real-life patient. This is an 84-year-old woman with a high risk of bleeding due to diverticulosis. She came at our hospital for a non-STEMI, where she had a depression of the left ventricular ejection fraction, 32%, moderate to severe mitral functional regurgitation. A real-life patient that we face every week in our hospital. So we decided to stabilize the patient and to bring her to the cath lab. We found a CTO of the right coronary artery and a diffuse pattern of atherosclerosis in the left coronary system. So what shall we do in this patient? First of all, we think at the opportunity, due to the bleeding risk, of using a DCB PCI, but we don't have to be too strict on this. So let's prepare the lesion and let's see how it looks. And then we decide if to put stents, if and where, and to use DCB for other lesions. So we prepared the lesions. Following our judgment, the lesion was well prepared, and we used 3 Paclitaxel DCB, one in the second diagonal branch, the other one proximal LAD, first diagonal branch, the other one mid LAD. Okay, this was the result. We did a shot, then we waited 8 minutes, and then we did another shot from another angle view. The flow was okay, there was a type A dissection, and then we decided to stop. Also because we brought the patient back after 2 days for a CTO recanalization, we were successful in recanalize this also by Paclitaxel DCB, and we finished. So another important topic in the complex lesion setting, this is anecdotal because we don't have data, but I remind you that we don't have data, or we have few data also with drug-eluting stents, is the use of Paclitaxel DCB for the management of chronic total occlusions, especially because we are not always sure about the real dimension of the lumen of the vessel when we reopen a total occlusion, totally occluded coronary arteries. So just giving some drug there without putting metal, which may incur into malapposition, can be a good solution. That's it. I'm done.
Okay, thanks very much, Bernardo. Now, pleasure to call on Miroslaw Ferenc, who's going to give his perspective, a complex case with angiographic follow-up, and discuss dissection healing. And then following that, we'll have some more time for discussion.
Yeah, dear colleagues, thank you for the invitation. And I was asked to find in our data some patient with long dissection and with angiographic follow-up. And so we are a high volume center, and I was happy to find a patient which is our daily routine patients. You will see such patients also many times in your cath lab. Typical STEMI patients around 50 years old, of course, smoker. They are usually 90% of cases smoker. And he came with a STEMI of anterior wall to the cath lab. And you can see this is a culprit lesion which was managed successfully, and the right coronary artery, there are some problems in the distal part, in side branches, and there was already some connection via collateral system from right to LAD. And so you can see there was this predilatation stent, and finally good flow, so this lesion could be treated very nicely. And of course, a few of you saw the occlusion, observed occlusion of the circ. There are some collaterals here, and we take a look to the patients, how is LV function, how was MRI result, and we found this patient has viability in the lateral wall. So we decided to bring this patient back to achieve complete revascularization, which was very useful in such young patient. So the patient came after 6 weeks, and we found a very good result after LAD. The ejection fraction was 35, and now we performed attempt to open LCX occlusion. This is just the view to the LAD, which was nicely open. There was a collateral flow from diagonal branch and from distal LAD to the circ, and we decided to go ahead with CTO of LCX. And you can see the branch is here quite large, but this is not so easy to find proximal cap, and we believed initially maybe there was some also collateral from the right, but it wasn't. And finally we go ahead with IVUS to find the origin of the proximal cap. This is really very helpful, and this is a tool which is very useful in the cath lab. And as you can see, we make a progress with the wire, but there was some segment where wire went subintimally. Finally, we found the distal part. The wire was perfect. We pre-dilated and then restored the flow. And the question was, what will be the next step? As you can see here, we had here good flow, but there was a dissection, and the dissection was starting practically here and stopping here, so really very long segment. So finally, the decision should be made. So what can we do? We even went with EVUS in this setting, and so long dissection and some flaps. However, the flow by angio was quite sufficient. So the decision was to make what to do, to use 2 long stents to cover this dissection, or to use maybe some drug-coated balloons. As you can see, this was the question which we discussed: 2 long stents from healthy to healthy segment, or to use as an alternative, because this guy is still very young. There was some left-man involvement, as you can see here, to use Prevail drug-coated balloons, and we wanted just to see, to collect experience with Prevail in such long dissected segments. And so this was the final result of the still dissection, and I was waiting again around 8 to 10 minutes, and after the really stable flow, we decided to stop the procedure here and to bring patient back after a few weeks. And between patients was fine. He came back completely asymptomatic. He was still a smoker. What we saw, there was improvement of LV function, so ejection fraction was now 47. And so finally we measured FFR for left main lesion. The FFR in ostial LCX was 0.81 and 8.2 in LAD, but there was still a problem in the proximal mid-part circ. There was a positive FFR 0.75. And you can see I'm here with Dr. Rahimi, and he was just taking a look after 6-7 weeks later, after Prevail balloons. And we have here Timmy flow 3, still dissection in this mid part, and we had impression, okay, there was some subintimal crossing with the wires. LAD was nicely open, so we finally decided to measure FFRs, and the FFR was positive, in this lesion here. The ostial here after this marginal branch FFR was still okay. So finally, we decided to stent this proximal area, and then finally, because there was a stent necessary to cover also this dissection. And how look at is so we had a view from the OCT, and you can see it look at not bad, partially subintimal crossing from the CTO attempt, but it looked at not bad. And here you can see on the right side, it was a partially some kind of septal flap. So finally, we went ahead, and this is now a final result. So we could avoid definitely a very initial, very long stenting of the circ, and we performed finally FFR guided procedure. So in summary, this was just after stenting, which was postulated, and in summary, I would say the use of drug-coated balloons was associated with healing of this long dissection in LCX. And even after CTO, PCI, we could save a distance of stents, and long stenting could be successfully avoided. And imaging and, as you saw, FFR tools are very helpful to guide multiple diagnostic and procedural steps. Thank you so much.
Okay, now we have the second part of discussion. I would like to launch the poll and then to ask Fernando a comment on the case, on this case that we have just seen. But first of all, I would like to launch the poll. The question is, how do you feel Paclitaxel DCB platforms should enter the routine practice in the complex lesion settings also as adjuvant, as a blended to drug-eluting stent? This technology still deserves more data, and we need more reliable randomized clinical trials. DS are and will remain the mainstay for such lesions, leaving Paclitaxel DCB only for easier lesions like side branch or in-stent restenosis. And the third question, the third answer is, we have sufficient data regarding the safety and efficacy of some Paclitaxel DCB, and we should use them also in the complex lesion setting. Now, I repeat, also with as an adjuvant therapy to drug-eluting stent. Please vote. And Fernando, can you comment on the case?
Well, basically, the issue here is whether or not we should use drug-coating balloons for total occlusions. And there is plenty of data in many de novo settings, right? Like bifurcation, small vessels, MI, and others. The data we got regarding CTOs is less sound, I will say. There is some data, but there is less data in this regard. So this is a beautiful example of how the theoretical advantages. So this, the remodeling, all the vessel that can be dissected and the stent malapose can be overcome just with a drug-coating balloon. But I find most people, experts in CTOs, most of them, probably because of the work you require to open the vessel, they do prefer still now to implant a stent with the feel that the vessel will remain open longer. It's a major work. Probably this is a bias, but most CTOs people will say, well, in this case, after 2 hours, 3 hours, I will fix it with metal.
Take a question from the audience, please.
Hello, everyone. Thank you for the excellent cases. I have a question or partially comment, Viktor Kochka from Prague. I am here because I still, despite the non-success of the bioresorbable technology, find the idea of avoiding stenting very intuitively correct. But I think the comment or the question on the last case is, I think we need to get the technology into the phase to compete with the stenting. It costs a fortune. The patient had to come back for another procedure. The patient ended with 2 balloons, and then in the second setting with 2 stents, and then needed an OCT to prove the report. And so I think, from my perspective, if we are to compete with the stenting, we need to provide, we need to streamline the procedure. We need to gain the confidence not to be bringing the patients back routinely, not to implanting them as a second stenting. This is economically not a viable option, at least in my perspective.
Yeah, thanks very much. Well noted. Tuomas, you have a comment there?
Yeah, we cannot take the patients back on routine basis. And in my practice, I would have finished the case in the first setting. I would have stented the part that there was a subintimal course of the wire, and then treated diffuse disease in the periphery with DCB. That's my practice in CTO. So you are correct that we cannot have control angios for every patient.
Yeah, and I mean, there's a natural tension. I think one of the things that we tend to focus on is very much getting it right first time. And there's a tension between that and an investment procedure, which I suppose has a role in certain settings. Here, there was a clear, relatively long subintimal course you could see beautifully on the IVUS. And it was interesting to see how it evolved in follow-up. Question from the back?
Yeah, so those of us with gray hair who have who've practiced for many years before the stents, we had 2 concerns. Restenosis was huge, but obviously drug-coated balloons can help resolve that. But the dissection was also big and scary. So I don't think there is enough experience to use drug-coated balloon and say that the dissection rate is okay compared to stenting. I don't think there is enough data. The cases that we saw today, one of them that you showed where you had excellent results in an LAD that was calcified, diffuse LAD, we don't usually see that with balloons. Okay, normally we see dissections, you wait your 8-10 minutes, sometimes you wait 15 minutes, and then you're worried that at night you're going to get called with an acute closure of an LAD. So that's going to be really the dividing point here. Otherwise, it's, you dissect and you put your drug-coated balloon. So that is concern. But I do have a question, a technical question. If you want to use a drug-coated balloon on a long length, how many times can you repeat the same balloon? Is it just 1 minute and then you have to switch to a different balloon?
Yeah,
okay,
you need to get another balloon.
Yeah, okay, I will leave you the reply for this question, but I have to comment on the first part. I have to say that I disagree with your point. We have a lot of data showing that even if we leave dissection with DCBs, there is no thrombotic issues. We have hundreds and thousands of patients enrolled in clinical trials where dissections were left, okay, probably 15 to 20, 25% of the entire cohort, and there was no thrombotic issue. So this is what we know. We know that if we have a final good flow and a type A or B dissection, you are safe. So this is one of the key messages that I would like to send from this symposium.
Flow is extremely important.
Flow is important, yeah.
So, I mean, of course, the other variable that's changed since the initial studies 25 years ago is the quality of the antiplatelet therapy and P2Y12 inhibition, which I think was the second piece of the jigsaw that makes people more comfortable.
Yeah, we didn't have those at that time, but I do like the concept, and I think that's always will remain the advantage of DCB over stents, is the nothing left behind concept. And that's something that is desired of the patients, the desire of communities, and if it's feasible, that's really going to be the role of DCB, because it's going to be very hard to show superiority on a randomized study of DCB of their DES. All what we're aiming is to prove non-inferiority. If you prove non-inferiority, you have the options, and then you have to do lesion selection. It's not for all the lesions, it's not for all the cases. We're not going to abandon drug-eluting stent. They're a good product. But you have another tool, because once you have in-stent restenosis, and we're talking about in-stent restenosis of drug-eluting stents, this is not anymore bare metal stent restenosis, then the recurrence rate, even with a drug-coated balloon or with another DES, is still double-digit. So there is definitely a motivation not to have the stent in the first place if you can avoid it in a lesion that potentially has a high risk for restenosis. But I think, remember that without large randomized clinical trials, we're not going to be able to substantiate this technology. You can show hundreds and thousands of cases like the one that was shown today, but we need a large randomized trial. That's the only way that stents were accepted in the community. This is how TAVR was accepted in the community. Now, more than 15 years now with DCB, if we want to get it, the DES for restenosis, it's not an issue, but if you want to get it for the novo lesions, it has to be large randomized clinical trials.
Okay, well, I think that's a nice message. Maybe a time for a quick comment from Tuomas.
Yeah, I think we have to remember that we treat the patient and not the vessel, so that especially high bleeding risk patients are increasing up to 40% of the whole PCI population are high bleeding risk, and 10% of them are getting a bleeding. So at least with DCB-only technology, you can cease the DAPT therapy during the first four weeks. It's very, very important in this population. But we need an RCT, as Ron mentioned.
So I think we're over on time. There's lots of questions that haven't been addressed on the chat, but thanks very much for the interactivity. The poll question you can see here in a maybe selected sample of participants with interest in the area, but I think you can see there's a split that more data is necessary, that DES are and will remain the mainstay, but there's a slight excess for that we have sufficient data to push us into the complex lesion de novo space at the moment, and I think that's probably a nice place to finish and to hand over to Bernardo now, who's going to sum up and close the session.
Okay, we've come to the end. So this is the key learnings that we should bring out from this symposium, hopefully, just to think at this possibility, especially in the complex lesion setting in our routinely daily cases. So the first question was to understand the role of Paclitaxel DCB in modern neurointerventional cardiology. Fernando already mentioned this study. In the instant restenosis setting, there is a trend towards lower adverse events, hard adverse events with drug-coated balloons, Paclitaxel drug-coated balloons, as compared to drug-eluting stents. There is an increase in the TLR, a slight increase in TLR, but lower other events. Okay, in the overall DCB for de novo and instant restenosis setting, there is from this study from Bruno Scheller a reduction in cardiac mortality at 3 years. Okay, this meta-analysis is not powered for cardiac mortality, but the signal is there. Okay, so the signal is contrary to the ones shown by the meta-analysis of Katsanos, and this was a patient-level meta-analysis. Second goal was to learn how to correctly prepare the lesion and obtain the best from this technology on the long term. So what is important, we didn't go very deeply in this part because we only had 60 minutes, but what is important is to understand the lesion that we have to face. Intravascular imaging in the complex lesion setting and in instant restenosis is of paramount importance to understand the lesion and to find the correct tool that we want to use in this patient. Then we reassess the lesion again, okay, and we decide if we want to use the DCB or if we want to convert to a drug-eluting stent PCI. Third goal was to understand the differences and advantages versus drug-eluting stents. This is easy task for me to remind you that we have no permanent cages, the flattening of the adverse events curves like the Bello study showed that at the 3-year follow-up, no need for prolonged DAPT, and possible, even this is a ground for future studies, single antiplatelet therapy. We have tens of patients treated with one single antiplatelet with no thrombotic events. And then the final goal was to understand the role of blended therapies in complex lesion setting. I would like to give you this final information, trying to avoid paving of our coronary artery patients and think at some possible blended therapies: drug-eluting stent, spot, short one, and DCB for the rest of the lesion. So thank you for your presence here, and hopefully next year we are here with more data on the topic.
Fusion, okay, fusion is good.